is Brooke Rossi. And hi there, I'm Brooke Rossi. I am a reproductive endocrinologist and infertility specialist at Ohio Reproductive Medicine in Columbus, Ohio. And we are doing this Facebook Live event today to celebrate National Infertility Awareness Week. So infertility, as you may know, affects about 1 in 7 people. And that's not even probably counting people who need help to have a family, same-sex couples, people who are parenting as single parents. And so it's probably even higher for people who need a higher number of people that need help growing their families. And so we're celebrating Infertility Awareness Week by having this Facebook Live event tonight. And before we get into questions, and of course, you guys are welcome to post questions at any time, I just wanted to tell you a little bit about this cool thing that we did yesterday. Yesterday, the Infertility Advocacy group Resolve and the American Society of Reproductive Medicine had an advocacy day, and it was pretty cool. So we had spent the last few weeks kind of preparing for it, and it was arranged such that we had kind of patients and providers from Ohio telling their stories and talking to a lot of different Congress people. So, you know, we talked to we talked to probably about 10 different House of Representatives reps, and also the 2 senators from Ohio yesterday. And so it was great. We had these wonderful patients, these brave patients tell their stories. And we had a couple doctors on the call as well from all over the state. And we had veterans and active military duty people. And it was all about trying to make sure that the Congress men and women knew that we wanted laws passed to help support family building, that helped increase access to infertility coverage for insurance. And it was great. I was so impressed by the patients that were speaking. And I really hope that we did some good yesterday. So anyways, that was another thing we did to celebrate National Infertility Awareness Week. And Boston IVF, one of the practices that we're affiliated with, has a lot of other events happening this week as well, that you're welcome to be a part of as well. So earlier in the week, we had some questions that people had sent in, and so we're going to go through those, and please feel free to post more questions. There's actually a few different questions kind of regarding maybe what's an IVF cycle? How is it counted? And how long does it take and all of that? And this can be a little bit confusing, I think, especially when we talk about chance of success and what constitutes an IVF cycle and chance of having a baby from a particular cycle and all of that. Excuse me. So an IVF cycle can basically be broken down into the stimulation cycle, the part of the cycle where the patient is taking hormone injections to get the ovaries to make several eggs. And then that patient has an egg retrieval, which is where the eggs are taken from their body. And then those eggs sometimes can be frozen if a person is freezing eggs, and often is put with sperm to create embryos. That might be the IVF cycle. Now, often those patients, so then from there, you have kind of 3 different options as I sort of describe it to patients. One option, once the embryos are created, is the person can have a fresh embryo transfer, which means that about 3 to 5 days after those embryos are created, either one or several embryos are placed into the uterus, and that's called an embryo transfer. So from the start of the ovarian stimulation to the embryo transfer to finding out if that person is pregnant, that can be about a month. So that's called a fresh embryo transfer. So the cycle is kind of from the time that the egg stimulation has started to the very end and finding out if that person is pregnant. The second option is to do something called a freeze-all. And there's several different reasons why we might do a freeze-all. So sometimes if a patient overstimulates, she may have a better chance of getting pregnant if she does a freeze-all and has a future frozen embryo transfer. The second reason why somebody may have a frozen embryo transfer might be if they have a polyp that comes up or a fibroid is noted. There may be something wrong with the endometrium or the lining of the uterus. And then another reason that we often will do a frozen embryo transfer would be if a patient's progesterone hormone level is too high on the day of the trigger shot, because that can be associated with a lower chance of getting pregnant. So if any of those things come up, the patient may create the embryos but freeze them, and we kind of call that a freeze-all, and that might be her cycle. And those embryos might be used the next month, or they could be used at any point in the future. And then the third option does involve a freeze-all cycle, but it may also involve doing preimplantation genetic testing for that patient. And there are 3 different types of preimplantation genetic testing. One that is used, it's called PGT-A, which stands for aneuploidy. And that's when we test the embryos to see if they have the correct number of chromosomes. So that can be things like, for a patient who may be over 35 and is worried about a higher risk of things like Down syndrome, that might be the testing that they choose. There's also called PGT-M, that is what we use for patients who they and their partners may carry a hereditary disease. And then there's something called PGT-SR, which is one of the, probably one of the least common types of genetic testing, but it's for patients who have something called a balanced translocation. So those embryos are grown, biopsied, then frozen, then we wait for the results, and then they have a frozen embryo transfer in the future. So I received a question saying, how long is one IVF cycle? Well, it depends on how you want to define it, but one cycle from the time that you start taking the stimulation medications to the retrieval is usually about 2 weeks. It kind of varies from person to person, but roughly it's probably like, 10 to 15 days. And then a frozen embryo transfer cycle, again, depending on how it's done, is usually 1 month. So that's how long a cycle is. I'm looking at my list here. So since we're talking about frozen embryos, we had a question about why some embryos are frozen and why some aren't. And maybe we can talk about freezing embryos for a minute. So this is not a rule, but there are many clinics right now, I would say probably most clinics that I know, usually will freeze what they call blastocyst embryos. And blasts or blastocyst embryos it's just the stage of development that the embryo is at. And usually it reaches that stage of development between 5 to 7 days after the retrieval. And so we know from data that when they're frozen at that stage, that gives patients a higher chance of having a baby from them. So we are very particular, like most clinics, about which embryos we freeze. And we make that determination about which embryos will be frozen, or again, for patients doing genetic testing, which embryos will be biopsied and then frozen, based primarily on what that embryo looks like. So that embryo is looked at underneath the microscope. And then there are some different things that our embryologists look for. So one, they're looking at the stage of development, like has that embryo gotten to where it needs to be at the right time? Almost kind of think about it. I think about it like, has the embryo crossed the finish line? Even if it crosses it at day 7 instead of day 5, has it gotten there? So that's the first thing they look at. The second thing they look at is sort of how the cells that make up the embryo look. Are they clear? And how are they organized within the embryo? Because we do know that embryos that are good quality, meaning have clear cells, have good organization of the cells, look normal, give us higher chances of getting pregnant, and are also more likely to survive the freezing and thawing process. And unfortunately, not all embryos are able to be frozen. And in fact, it may only be about 30% or so of the embryos. And we know that, we know that not everybody has embryos that can be frozen. And I think it's important to maybe have people have realistic expectations about how many embryos are normal. So, if you have 15 eggs or 15 embryos, that might be great, but you might only have 4 or 5 frozen, and that's okay. That's just biology, unfortunately. The reason why clinics are so selective about which embryos are frozen is because it's a big investment for our patients in terms of time and money to have a frozen embryo transfer. We want to give them the best chance they can. And we don't want to freeze or lower quality embryo because that embryo then will give them a lower chance of getting pregnant. So that, I think, in general is why most clinics are selective about the embryos that they freeze. So a good embryo has to do with how it looks and how its development has been from when it's in the laboratory. I'm sorry, I'm just reading this question here that I got. Yeah. Yeah, it looks like, I'm looking at a question from one of the participants tonight, and it looks like she unfortunately did an IVF cycle and then had a loss. It looks like kind of well into the second trimester. And this can be really difficult for patients to have a loss at any point. And I know I've sat with so many patients who are having miscarriages and, in the moment look at me and say, I'm never doing this again. And often it's so hard when that's happening to somebody that we just take a breath. We figure it out later. And often, people, want to try again when they are able to recover from sort of the difficulty of having the loss in the first place. When people have a miscarriage, it is sometimes helpful to try to figure out what the cause of that miscarriage was, because it can help us try to understand how to prevent it from happening in the future. So there is a condition called recurrent pregnancy loss, and recurrent pregnancy loss is when a patient has had 2 or more pregnancies that have not continued and given that person a baby. And it's kind of older teaching that it's 3 losses. So sometimes I'll see a patient who is told, oh, well, we're not going to be testing until, it's been 3. And that's not really what the recommendations say anymore. So it is reasonable to have an evaluation after 2 losses. And it doesn't even have to be really like what we call a clinical loss, which is when you see the fetus and the heartbeat and all that stuff. It can really just be any pregnancy that hasn't continued. And, when we see a patient who's had a loss, or when we see a patient that's had more than, I should say, 2 or more losses, then we're looking for things like hormonal abnormalities, like looking at their thyroid, looking at their blood sugar, looking for diabetes, looking at their prolactin level. We want to look to make sure that their uterus has a normal shape, that they don't have any, what we call congenital anomalies of the uterus, like a uterine septum. We also want to look for things like antiphospholipid syndrome, which is what we call an acquired bleeding disorder, which means that a lot of the bleeding disorders are genetic, but this would be one that could actually happen, like you could acquire it or get it as over time. And that actually is something that you should look for even if someone's had a second trimester loss. So, if someone's experienced a second trimester loss, even if that fetus hasn't had any testing done, or if they're told like, we don't know what happened, I usually will test people for antiphospholipid syndrome because it can be part of the criteria. And then sometimes, we want to look for things like something called a balanced translocation. These are things that aren't picked up easily on routine genetic testing. And, I recently found a patient who had a child who had a second trimester loss and was found to have a balanced translocation. So, I would encourage, if anyone's had a second trimester loss, that they try to get a little bit more information about what could have happened from their provider. So, okay, we have a question about what the difference is between insemination and IVF. So there are so many letters and acronyms that we throw around in our world. My favorite is there's something called an HSG, which is an X-ray test of the fallopian tubes. And there's also a test called an SHG, which is an evaluation. So one stands for hysterosalpingogram, one stands for saline or sonohistosonography or something like that. And even in the office, we get them confused all the time. So that we have HSG, SHG, IUI, IVF, ICSI, PGT, all of these things. But okay, so IUI stands for intrauterine insemination. And every once in a while, actually, we kind of sometimes in our office throw around this old-fashioned term also called TDI, which is the terminology that sometimes we use for a person using donor sperm. It stands for therapeutic donor insemination. But anyways, sometimes people just call it DI, donor insemination. So intrauterine insemination, or IUI, is when the sperm is placed into the uterus. So on the day of ovulation, a person would come into the office, and this little tiny catheter is used that goes, so the woman comes in, she has a speculum exam, we look at the cervix, and then we use this little tiny like catheter to put sperm up into the uterus. And that sperm has also been prepared. So it's been kind of like filtered, and so it's like, so we can safely put it into the uterus. So an intrauterine insemination means that we're putting the sperm into the uterus. Again, it can be used with partner sperm, donor sperm, directed sperm. So if it's not necessarily your partner, but you want to use someone's sperm that you know, it can be that. So IVF stands for in vitro fertilization. And in vitro fertilization means that we grow the eggs by giving a person hormones. Then that person has an egg retrieval. We also obtain sperm, and then the sperm and the egg are put together in the laboratory. That fertilization happens in the laboratory, embryo is created, and then that embryo goes into the body kind of in the same way with a little tiny catheter up through the cervix. So the important distinction with IUI is that everything still happens in the body. Fertilization, embryo growth, everything happens in the body. IVF, those steps happen in the laboratory. So IUI is a great option for many patients. I mean, it's usually the first step of infertility treatment for a lot of patients. It works great. It's pretty low tech. It's relatively low cost compared to everything else. And it works for a lot of people. However, it does, for an IUI to be successful, the sperm have to be good enough and the fallopian tubes have to be good enough too. With IVF, if there's any concern for like either of those issues, the sperm or the tubes, IVF is usually the best option for patients. So, so I have a question about says two moms wanting to start trying for a baby. So that's great. We do that all the time. And I think there's a lot of same-sex couples in Columbus and definitely in our practice. I think for patients who are wanting to use, so if you are a woman who has a woman partner, or you are a person who wants to use donor sperm, either with a partner or not, most people would choose to use sperm from a sperm bank. But we do have some patients who have identified someone in their life that they want to be their donor, and we can do that too. It just requires a little bit more testing and contracts and all this stuff to make sure that it's done safely. I would say the first step, if you are in a same-sex relationship and wanting to use donor sperm, I mean, we're always happy to see people kind of right out of the gate and talk to them about donor insemination. Sometimes the evaluation involves an assessment of, you know, any, I guess we call it kind of infertility risk factors. So we may talk to patients about how their periods are, how their overall health is there any identifiable hormonal issue? Is there any event that happened in their history, like prior pelvic surgeries, prior pelvic infections that may affect their fallopian tubes and that sort of thing? And then we would talk about, you know, the donor insemination process, which again is quite simple. I mean, the other thing to sort of think about as you're planning, for some couples, it's very clear who wants to be the mom first or who is not interested in being a mom of the couple. And so that's sometimes helpful. Usually, you know, if there is a kind of an age difference between the two, we sometimes, and both people want to carry a pregnancy, we may want to have the older person do it first. Sometimes we do something called reciprocal IVF. So, you know, we have many couples who one woman will say, I'm sorry, you guys, my dog is barking for some unidentifiable reason. Sorry about that. Anyways, we may have one woman who says, look, I don't ever want to carry a pregnancy ever. But I want to have a genetic link to this child. So that person may go through an IVF cycle, create donors or create embryos and then put it into the other woman. So it's common. It's actually not that medically complicated doing donor insemination or helping same-sex couples, and we're always happy to help you out. All right. I have a couple questions on this, and I'm going to address this. So a couple people have asked about when do you stop doing IUI or insemination, and when do you think about doing IVF? And that's kind of a tricky answer, but let me kind of give you a couple little bits of information. There were some very good studies that came out a few years ago, which have kind of dictated the management of patients with infertility. And what I'm specifically talking about is something called unexplained infertility, meaning that if you don't know what's going on with a patient, like fallopian tubes are good, hormonally good, sperm looks good, the first step for those patients should be that they consider doing medicated IUI. Usually by medicated, we mean either having that patient take Clomid or letrozole. And in these studies, they had patients do that 3 times. And they're always talking in infertility studies about something called cumulative pregnancy rate, which is like, if you took 100 couples and they all did a medicated IUI, then about 10 of them would have a baby. Okay. Then if you took the remaining 90 and did a whole nother round of treatment, about 10 more. So you took the remaining 80. So that's what we mean by cumulative. And what they found was after about 3 cycles of medicated IUI, the chance of getting pregnant started to go down. And it's not that the procedure was less successful. It's like the people that were left in the group that didn't get pregnant with the first 3 may have an issue going on that isn't getting fixed by the medicated IUI. And so it may be that those people that are left need IVF to help them conceive. So the recommendations have basically said IVF should be discussed if someone has done 3 medicated IUIs and they haven't conceived. Now, everyone's a little different, right? And so sometimes, and this is a little bit of my kind of personal thought on this, like, if I have a couple and the sperm's not that great and I really think that they haven't had a good shot at it, and they don't want to do IVF or they don't have coverage for IVF, maybe we would try 3 to 6. Or again, like maybe you have a person who's, in their late 30s or early 40s and they're saying like, I feel like I need to do IVF. I want to do IVF. I don't know, maybe they would do it after 1 or 2. But I definitely think that, after about 3, it should at least be brought up. Like, is IVF right for the patient? The answer may be no, or the answer may be, well, we want to do a couple more, or remember that one IUI, the count wasn't that good. Does that one really count? Maybe we should do another one. But, it's really hard, as you know, to not get pregnant. And so we definitely don't want to just keep doing things that aren't working and having people unnecessarily suffering and paying money and doing all these things that aren't working when it may be that they really need IVF. So that was a very long answer to the question of probably about 3 to 6. And at about 3, usually we're having conversations with our patient about what their plan is for the coming months. So we have a question. We have a question about PCOS and if PCOS affects the chance of having IVF. Kind of depends. I mean, in some ways, PCOS patients, they often have very good ovarian reserve. And so they are the type of patients that can give a lot of eggs and have a lot of embryos. We do sometimes see differences in embryo quality with PCOS. But, I think that we have very many patients getting pregnant with PCOS. And so, I always think it's reasonable, to talk with your doctor about, is there any other thing you can optimize? Like, are you taking your prenatal vitamins? What's your vitamin D level? How's your weight? Like, is there any supplements that would be good? Like, is there any other thing? You can't get rid of the PCOS, right? Like, it's just, you can't cure yourself of it. So is there any other thing that you can do to kind of how's the sperm? Like, is there any other thing you can do to try to optimize things, understanding that your PCOS is just part of you and you want to try to optimize other things as best as you could. There is another patient who is asking, what are some of the initial tests that we do for infertility? So the way that I always kind of think about it and describe it to patients, they probably get tired of hearing this, but so you always think about, okay, like what does it take to get pregnant? Well, you need to have like the brain and the ovary need to communicate with hormone messages to try to, and the brain tells the ovary to make an egg, and then that egg gets released, and that's called ovulation. Then that egg has to kind of like get up into the fallopian tube, and then the sperm and the egg have to meet in the fallopian tube, and then fertilization has to happen. Then that fertilized egg or embryo has to move into the uterus for implantation to then happen. So our initial tests with IVF actually kind of evaluate each of those steps. So we may do just a regular history and try to understand if somebody's ovulating. We may do hormonal tests to figure out if somebody's ovulating. So usually blood work is part of the initial evaluation. Next, depending on sort of what's going on with the woman and her age, we may do ovarian reserve testing. That might be with a day 3 FSH and estradiol level. It may be with an AMH or an anti-Müllerian hormone level. It may be with an ultrasound doing something called an antral follicle count. So that's the assessment of ovarian reserve. We may do an evaluation of the fallopian tubes by looking at either an HSG, which is an X-ray test of the uterus or the fallopian tubes. And some practices, they also will do they call it like a bubble test, or kind of like a saline ultrasound, where they'll like put water in the uterus and try to see if the water comes out the tube. So that's another thing that people will do to try to assess tubal patency. And usually one way or another, the uterus gets evaluated because you can kind of see it either with the HSG or with an ultrasound. And then often if there's a male partner involved, then a semen analysis is done as well. And that's kind of the basic testing for an infertility evaluation. And an infertility evaluation, it is recommended that an infertility evaluation be done. If a patient is 30 years old, I'm sorry, 35. Let me restart that. If a patient is 34 or younger and has tried to get pregnant for a year and has been unsuccessful, that would be the recommended time to go ahead and do an infertility evaluation. If the patient is 35 or older, usually we should be doing an evaluation if they have not conceived for 6 months. And, I'm always trying to figure out with people when I first meet them, like sometimes people will say, well, we weren't like trying. And I always think, if someone's like, and I don't know how else to phrase this, but kind of like been exposed to pregnancy. So what I mean by that is if somebody says, well, we've only been like really trying and doing ovulation testing and tracking cycles for 7 months, but they've been off contraception for 3 years and they have sex a couple times a week, like that's a long time, So I think there can sometimes be a difference between trying and being exposed to pregnancy. And I think if you could have become pregnant and you didn't, then that would be a reason to, again, seek some consultation. All right, let's just talk real quickly about I have a question about fertility preservation and egg or embryo freezing. And this is something that's more common now. Egg freezing has been non-experimental for about the last 10 years. And the whole idea with egg freezing or embryo freezing or any sort of fertility preservation is that as we get older, our eggs lose their quality and are less likely to help us have kids down the road. And there isn't like a perfect time to freeze eggs, although, we don't do it in, if somebody showed up at my office and said, oh, I'm 25 years old, I want to freeze eggs, I'm not sure we would necessarily recommend that because they still have a lot of time before their fertility starts to go down, and fertility probably starts to go down at about 33, 34. So I think if somebody is in their 30s, it's always reasonable to consider it, even if you're in your late 30s. Because if you think to yourself, well, if I don't freeze my eggs, like what are your other options? And the other options are things like, I'm embryo donation, egg donation, adoption, and those are all fine options. So I think that if a woman comes to talk to us about egg freezing, or if a patient comes to talk about egg, and this is just elective, right? So obviously if, somebody has a medical condition or cancer or something, then that we usually will do it at any time they need it done. But I don't think that the late 30s is inappropriate to consider doing fertility preservation. Ideally, maybe in the mid 30s, but late 30s is fine. Any age is kind of fine, as long as you have a very upfront conversation with the provider about what your chances are. And there are some nice papers and calculators out there that help women figure out sort of how many eggs they may get, and therefore what their chances are from that cycle. And most people would probably freeze eggs. There are some people who would say, I don't have a partner now, and I'm probably going to use a sperm donor down the road to be a single parent. So maybe I'll just freeze embryos, and that's totally reasonable too. I've done that before for people. I've had people who freeze eggs, then come back and do donor insemination, or come back and thaw the eggs and use donor sperm. I mean, these are all options. So I just, I think egg freezing is really fine at any age, as long as there's a very honest conversation about what the risks and benefits are. And quite frankly, the risk is quite low, like the medical risk is quite low. It can be, the cost can be anywhere, depending on insurance coverage, anywhere from like $5,000 to $10,000. So that would, that's kind of, I think, the risk, like the financial risk that people talk about, but it's always reasonable to do. I don't think the late 30s is too old. There's another question about when to have a baby after, like when to start treatment again after having a baby. And that can kind of vary from person to person. So if you are somebody who had a baby and is thinking about infertility treatment again, kind of depends on, one, what your obstetrician says. So if they've told you, hey, you had a C-section, I really want you to wait 9 to 12 months before you get pregnant again, that might be something to consider. If you're breastfeeding, sometimes that's something to consider, because sometimes we can't do treatment if people are breastfeeding. But it also never hurts to just come and meet with your infertility provider and sort of get a game plan, right? So like, even if you're 9 months postpartum and you want to use your frozen embryos or do an IUI, it never hurts to just meet with them and sort of say, okay, like, what's our game plan? Like, how's your health? Are you on new medications? Like, how's your weight? Do we need to check your thyroid? Like, whatever, you can figure out all that stuff and make a plan to start. So it never hurts to just sit down and figure out what you want to do next. Somebody asked a question about infertility, having an impact on their sex life. That is absolutely the case. There's so many of our patients struggle with this, and whether it's because patients have pain from endometriosis, or whether maybe their partners have some sort of erectile dysfunction or ejaculatory issues, and sometimes these issues kind of pre-exist and people are kind of getting through it, and then all of a sudden they start infertility treatment and we say, okay, now go ahead and have sex every other day, and that can be really, really hard on couples. So if it's really seeming like a barrier, then probably that's a good reason to think about seeing like a therapist, like whether it be a sex therapist or a counselor or something like that. I have had some patients try to just tone it down a little bit in terms of like the amount of stress they're putting on themselves or their partners. Everyone's like tracking their cycle with their apps and like sending texts to their partner saying like, we have to do it today. To the best of your ability, like maybe try to like just not make it so stressful although sometimes, the partners are aware that they're all suddenly, having sex every other day. And also understand that you're just doing the best that you can. And, for a lot, especially for our patients who are doing insemination, like in a perfect world, people would have sex every other day and then have the insemination and then maybe have sex again. But like, if you can't, you can. Probably the most important thing is to just make sure that we get a sample for the insemination. And if you have sex another time, great. If not, you can kind of just know that you have a good chance with your IUI. But and also just recognize it's really hard, and try to support each other and not blame people, and just do the best that you can, because that's all you can do. I have another question about how many rounds of IVF do you do before you tell a patient it's time to move on? That's a really tough question too. It's kind of like the IUI question. It really depends from person to person and what's going on. I think the most important thing with that is that somebody is, that you're making sure that your provider is like looking at things each cycle and sort of like going through things and identifying like what happened, how are things going, was there a problem, how are we going to address the problem, or like what are we going to do differently, and sometimes we can, like, we can try different protocols, we can try different medicines, we can try things to help egg maturity or embryo quality or sperm quality, or more testing can be done. And so, and there are some things that we have a hard time fixing with IVF. There are some patients who have decreased ovarian reserve. There are some patients who have other issues. So it's hard to say how many cycles it's okay to do. I mean, quite frankly, one of the most limiting factors, at least in Ohio, is the cost of doing IVF. So some people can't just keep doing IVF because they don't have the funds to do so. But I just think the most important thing is that your provider is talking with you about each cycle and what happened and what can be done, if anything, to make it better the next time. I have a question about donor eggs, and yeah, so just real quickly about egg donation. Currently, there are a couple options for using donor eggs. One is using what they call like it's like using like a fresh egg donor, where you pick your egg donor and they donate eggs specifically for you. And then there's egg bank or frozen eggs that you can use as well. And truthfully, all in all, there's probably a little bit of a decreased chance of getting pregnant with frozen eggs than with a fresh donor, but it's still very good. And I mean, it's it's kind of like a normal just thing that people do in 2023. We've had many patients get pregnant using frozen eggs. And the question I got in particular was in women who are over 40, but really the success of an egg donor cycle really shouldn't depend on the age of the woman who's receiving the eggs. Like that really is kind of standard, because as long as, her uterus is okay, the age of the woman accepting the eggs should not impact success. It's the age of the woman giving the egg that affects success. And, we have good success with women using frozen eggs from an egg bank. And for some women, it's been a great option for them to use frozen eggs because there's a greater selection of donors. And we have, I'm just looking at a couple other questions here. We talked about that. Someone asked a question about with the chance of having twins with ICSI and what happens with unused eggs from the retrieval. So there shouldn't be a greater chance of twins with ICSI. So ICSI is when we put the sperm directly into the egg. That's a way that we fertilize the egg. It's primarily supposed to be used for men with male factor infertility, but can be used. There are a lot of clinics who just do it on everybody. So that's okay too. And that should not affect twin rate. The chance of having twins with IVF or with any infertility treatment is really based on sort of how many fertilized eggs there are available. So usually, I mean, the standard now with IVF for anybody who's done genetic testing on embryos or for anybody less than 38 is to just have one embryo transferred. So if you have one embryo put into your uterus, chance of twins is probably really about 1%. And then somebody asked a question about what happens with unused eggs after the retrieval. So standardly, all the eggs are used for the retrieval. Usually all the eggs that are mature that we get from a person, we will fertilize. The embryos that are remaining that are not good quality usually are discarded, meaning if they can't be frozen, they're usually discarded. I would say that's the standard way to handle extra embryos that are not good quality and can't be frozen. So I have a question about frozen banks. What frozen banks have more options for Asian donor eggs? So this, this brings up a good point about egg banks or egg donors in general, is that one of the, I think, nice things about egg banks has been that it offers more options for our minority patients because there are not as many minority egg donors out there. I don't know the exact Asian egg banks. I know that there are some out there. And so I would definitely look into that. I hate to say, you can probably just Google Asian egg banks, and I know that they're out there. The only other tricky thing with egg banks, and this is true of our clinic, I don't know about other clinics, is because freezing and thawing eggs is a very precise process. Not every egg bank works with every clinic and vice versa. So you just have to make sure that, as you're looking at, if you're tied to a specific clinic and you really want to stay at that clinic, you may want to ask that clinic which egg banks they work with. Alternatively, if you really want to use a certain bank, that bank may have an idea about what clinics they have worked with in the past. So we're going to just do one more question here. And I'm just looking through that. Okay, so I have a question about how often we should repeat hormones for the evaluation and treatment of infertility. I don't know, I usually, depends on what it is. I think a lot of us recheck hormones about every year or so. If somebody has a totally normal vitamin D level 15 months ago, I might not recheck it. But if somebody's had their thyroid checked and they're on medicine, that might be something to check. An egg reserve, like an AMH, especially if somebody has, is over 35, that should probably be rechecked every year or so. Thyroid should be checked about every year or so. HSGs, like fallopian tube tests, I usually don't make people do that all but once because it's horrible. And I didn't say horrible. It's not horrible. It's just, it hurts a little bit. But don't be scared of it. You should still consider doing it if it's been recommended by your doctor. Sometimes ultrasounds are nice to have because things can come up like fibroids and polyps and that sort of thing. So, if you're in active treatment and, and you haven't gotten pregnant in a year, that definitely should cause someone to do some more testing. So. All right, everybody. Well, thank you so much for joining us tonight. I'm happy to meet with you again in the coming months. If you feel like this is something that's been useful, please let us know. Happy Infertility Awareness Week, and I hope you can take part in some of our other events that we have going on. And please support each other out there and remain hopeful and all of those things. So good luck, and we'll see you soon. Thanks so much.